Hello, everyone. My name is Ed Stuher, and I'm president of the National Foundation of Swallowing Disorders. I'm thrilled that you've taken the time to join us for this event this evening. I'd like to give a shout out to our foundation's executive director, Elizabeth Lipton Bailey, whose technical and organizational skills have made this event and past events that we've held possible. So great job, Elizabeth. She's really the muscle behind making these events happen. Many of you are familiar with the foundation, and our mission is to make life better for all those with a swallowing disorder. And we do that through 4 primary pillars: by providing direct patient support in the way of referrals, 15 in-person swallowing support groups, and 2 very popular Facebook forums. The pediatric forum receives almost 1,000 posts per month. We also host educational events such as tonight's webinar, raising awareness, which I'll come back to, and promoting promising research. You will be muted during the presentation, and to ask for a question, click on the blue question mark to type in your question at any time. Our keynote speaker tonight is going to wait until the end of her presentation to answer questions, but as they come up, please use that and ask them as they happen. The foundation, recognizing the need for change and to help show solidarity, would like a few moments of silence. Would like to take a few moments of silence in support of Black Lives Matter. As an organization, we're working to put our words into actions and welcome input from our community. At this time, please take a moment of silence to reflect on what you can do to help push equality for all. Thank you for participating in that moment of reflection with us. The NFOSD is, this webinar was made free of charge thanks to the generosity of an unrestricted educational grant provided by Bracco Diagnostics. We're very appreciative of the long-term support provided by Bracco Diagnostics. The NFOSD is proud to recognize the following sponsors of the Dysphagia webinar series, including Clear Dysphagia Aid Beverage and Food Thickener, Medcoat, and Mira GTX. who is now recruiting head and neck cancer survivors with dysphagia to a clinical trial investigating a new drug to combat exostomia, or otherwise known as dry mouth. As many of you know, June is National Dysphagia Awareness Month, a statute passed by Congress in 2008. We invite you to join us for our ongoing awareness and fundraising initiatives. We're hosting frequent t-shirt giveaways throughout the month, in addition to sharing stories from people impacted by dysphagia of all ages. If you haven't already, please follow us on Facebook and Twitter to learn more. We're seeing a reach of about 20 to 25,000 people daily from our Facebook awareness campaign. So between that, Twitter, and our website, we expect to reach about 750,000 people this month with our dysphagia messaging. So please participate in that with us. I would now like to introduce you to our guest speaker, Melissa Farrow, who has volunteered her time and expertise to present on this topic tonight. Melissa is a speech-language pathologist who is board certified as a swallowing specialist by the American Board of Swallowing and Swallowing Disorders. Melissa works as a speech-language pathologist for the Texas Health and Human Services Commission, where she serves as chair of the Physical Nutrition Management Team in caring for those with intellectual disabilities and complex medical conditions. Melissa conducts research in dysphagia management and oral care in those with intellectual disabilities, and has been invited to present her work both regionally and nationally. She is also an active member of several organizations dedicated to advancing the art and science of swallowing and advocating for patients with swallowing disorders. Melissa, at this time, we'd like to turn this over to you, and we're honored to have you with us this evening.
Okay, thank you so much. I am so excited to be here. Let me get my slides up and we can get going. So, like I said, I'm really excited to be here and discuss the topic of dysphagia in those with intellectual disability. I have been working for the state of Texas at an intermediate care facility, and it's been exceptionally challenging, but also very rewarding to work in this setting. And so I'm really excited and glad to be able to share some of my insights and my experiences with you all here tonight. Many of you may not be familiar with the intermediate care facility setting, otherwise known as the ICF setting here in the US. I know I certainly wasn't before I started working here. And just for clarity's sake, when I say ICF, I'm not referring to the International Classification of Functioning Disability and Health, which also uses the same acronym ICF. So just so that you can be nice and confused, I'm talking about intermediate care facilities. So I don't really have enough time to get into the nuts and bolts of an ICF. But if I were to give you an elevator speech on what is an ICF, I would say that in Texas, we are a group of facilities across the state that are really designed to support people with intellectual disability. So we are charged with helping people to learn new skills or to maintain their current skills so that they can really live in the least restrictive setting possible. We are not considered a permanent residence for the people that we serve. So we're not long-term care, we're intermediate care. So we're just kind of a stepping stone to another setting that would be their long-term setting where they can live independently, as independently as possible. While they are living in our facilities, we provide them with all the services that they need. So we provide their medical care, their residential services, their social services, any habilitative services that they need in order to support their daily activities. That's kind of what we are in a nutshell. And if you want to know more about the ICF setting and the ICF model, I'd encourage you to check out the CMS website, the Center for Medicare Services website, for more information on how ICFs are regulated and what types of services we provide. On that, my first screen here is the website if you want to navigate to that. So these are my disclosures. I'll just let you read those at your leisure. And here is what we're going to be chatting about tonight. This is kind of the roadmap of where we're going to be going in this next hour. So let's jump in here and start off with talking about or defining what intellectual disability, or ID, as I'll be calling it, is. ID is a lifelong disorder that's characterized by limitations, significant limitations in intellectual functioning. So those areas of reasoning, learning, problem solving, judgment skills, as well as adaptive behaviors. So activities of daily living, things like communication and independent living skills. Those things are limited in persons that have intellectual disability. ID is usually defined in early childhood, but by definition, it originates before age 18. And ID affects about 1.5% of the total population, or about 6.5 million people in the US. Although globally we have estimates around 200 million people, sorry. But it's really difficult to compare prevalence statistics among nations because database and classification systems and criteria vary widely from one nation to the next. So that's kind of a difficult number to get at right yet. Intellectual disability can originate from a variety of causes, and most of these causes have the potential to impact swallowing function. These can include chromosomal abnormalities, things like Down syndrome, Fragile X, Angelman syndrome, changes in embryonic development, prenatal effects of drug and alcohol use and things like that. Any other types of pregnancy issues, acquired childhood diseases or injuries, childhood onset psychosis and autism. These are all possibilities for causes of intellectual disability. But we also have intellectual disability arising from unknown mechanisms. This accounts for a substantial number of cases throughout the world. And I know even on my caseload, there are lots of times where we don't really have a set etiology on what was the cause of the intellectual disability. So historically, there have been significant health disparities between those with ID and the general population. So, just looking at these numbers here on this slide, we can see that life expectancy over the last, say, 90 years has gotten better. It has increased, but it continues to lag behind the general population. And actually, when you look at the mortality data, it indicates that it's really only been in the last century that those with ID are actually living to middle age. So while adults with ID are now forming a small portion of the older population in the community, on average, they still live around 20 years less than the general population. Now, the reasons for the lower life expectancies that we see, they're really multifaceted. They have to do with things like access to care, socioeconomic status, and then a big part of it is this frequent occurrence of multiple comorbidities. So here are some of the common comorbidities that you might see in those with intellectual disability. These are not any different than comorbidities that you might see in other adults, but what's unique here is that unlike the general population, these comorbidities are prevalent at all ages for those with intellectual disability. So understanding how these co-occurring conditions affect the swallowing system in those with ID is really vital in managing their health needs. This is because these types of conditions often complicate swallowing assessment and treatment, and at times they can cause restrictions to your management plan. So the things that you might want to be able to do, you can't do because of these co-occurring conditions. It's just not going to be as effective. So things that you want to think about might be in terms of sensory deficits. For example, how are you going to incorporate safe swallowing strategies for a person who is deaf-blind and is also very impulsive with self-feeding? In terms of seizure disorders, how do you balance the need for medications to control those seizures and seizure disorder with the impacts that those medications have on swallowing safety and efficiency? What, in terms of psychiatric conditions, what are the effects of long-term antipsychotic medication use on swallowing? And what is the likelihood of decreased compliance with any recommendations that you might have to manage this person's swallowing problems in the face of challenging behaviors that they might have related to their psychiatric disorders? How will mobility impairments impact the amount of assistance that somebody might need during the mealtime process? And what esophageal issues and how esophageal issues related to, say, esophageal structural abnormalities, physiologic dysfunction, or maybe even medical interventions like fundoplication, how are they going to impact swallowing function? And then how will oral health status influence your dysphagia management decisions? Honestly, oral health in ID could be a webinar in and of itself. We know that dental caries and periodontal disease are actually reported as the second most common secondary, condition affecting people with intellectual disability. So oral health is really important, and I just want to touch on it for just a few minutes here. We have a very large body of literature that has examined the oral health status of those in ID. And what that literature has shown is that in the ID population, we have a higher prevalence of periodontal disease than in the general public. There was a very large retrospective study that examined the oral health of over 4,000 individuals with ID, and this study found that almost 90% of the population, the study population, presented with dental caries, so cavities, and 30% of those had cavities that were untreated. This study also reported that the overall prevalence of periodontitis was 80%, and we saw that the highest prevalence was in those that were 50 years and older. So research has also demonstrated that individuals with ID are often unable to receive adequate dental care to maintain good oral health. And as a result, adults with ID are 10 times more likely to have missing teeth than the general population. Now, part of what is influencing these findings is that really the oral health needs of individuals with ID are pretty complex. And this is often related to their underlying congenital or developmental abnormalities that just makes that oral cavity in the dentition very unique and sometimes difficult to manage and keep healthy. But there's another factor, an inability to cooperate during dental exams is also a major factor in poor oral health outcomes in those with intellectual disability. Several studies since Dr. Langmore's seminal work, which really identified oral health as an independent predictor of pneumonia, have explored the relationship between oral hygiene and pneumonia. In 2003, there was a systematic review that looked at periodontal disease and pulmonary health, and this review reported that people with colonized dental plaque were 9 times more likely to develop pneumonia. Then in 2006, another systematic review that looked at respiratory disease and overall oral health reported that the presence of periodontal pathogens in saliva, as well as multiple decayed teeth, were very important risk factors for pneumonia development. In 2008, a retrospective study on the number of pneumonia-related deaths that were associated with periodontal disease showed that those with at least type 3 periodontal disease were almost 4 times more likely to die from pneumonia. So, given all that information, and given the fact that periodontitis is highly prevalent in this population, and couple that with the fact that respiratory tract infections are the leading cause of death in those with intellectual disability, oral health should absolutely always be on your radar whenever you're developing your dysphagia management plan and doing any kind of assessment in this population. So let's look at the natural history of dysphagia. It's very unique in this population, and that's because the pediatric swallowing and feeding disorders that occurred either in infancy or in early childhood will likely persist into adulthood in this population. Right now, there's no reliable data on the prevalence of dysphagia in people with ID. We do have estimates. Estimates range between 36 to 70% of those with ID have some type of swallowing impairment, some type of impairment in swallowing function. And we do know that dysphagia prevalence is higher in those with ID at any age than in the general population, and that dysphagia prevalence is greater as ID severity increases. We also see that dysphagia prevalence increases with things like aging, with multiple medical disorders, and with polypharmacy, so taking multiple medications. So really what actually happens is the effects of things like aging and acute illness are imposed on an already taxed swallowing system. So what manifests is a combination of developmental and adult onset issues, and this is really very unique to this population. Unlike other populations, there's a high prevalence of disorders in functional foundations in those with ID. And functional foundations, these are those functional abilities that are needed in developing and maintaining good swallowing and feeding function throughout your lifetime. So these are going to include those postural alignment and mobility disorders that impact somebody's ability to either maintain stable upright positioning during eating, or even to be moved into place during swallowing activities. Communication disorders that impact eating in terms of abilities to express preferences, to indicate hunger, and to enjoy social interactions during mealtimes, which we all do, the sensory capabilities of vision and hearing, and the psychiatric and psychosocial disorders that really can negatively impact eating behaviors. In terms of contributing factors, there are many factors that we need to consider in identifying or trying to identify the causes of feeding and swallowing disorders in those with ID. These factors are really associated with the neurologic and neuromotor impairments, as well as those anatomical abnormalities that will result in physical disabilities, in psychiatric conditions, and in intellectual dysfunction. So they kind of all come together. And then what we get, you can see at the bottom of the funnel, is that dysphagia severity in this population is really typically associated with the severity of the underlying issues. So those underlying psychomotor, psychosocial, or cognitive impairments are going to be the factors that contribute to the overall dysphagia severity. So in terms of system effects, dysphagia in ID varies from a mild disorder where we only need a few strategies in order to maintain good health and positive quality of life outcomes, to a profound disorder in which we need something like alternative nutrition and hydration in order to maintain health status and quality of life. Typically, dysphagia in those with ID is complex, and it involves multiple body systems and very often multiple phases of swallowing. So when we have these together, they combine to subsequently cause, I guess, a risk for negative health consequences in this population. And those are going to be, these are just some of them that I listed here, but the big ones, I guess we could say, choking for sure, respiratory illness and respiratory compromise, as well as nutritional inadequacies. So dysphagia in this population can be divided into several categories, and each of these will likely constitute a different type of management plan. So let's look at these. The first category is what's called transient dysphagia, or just temporary dysphagia. And this category is particularly important and significant for people with underlying chronic dysphagia, as they cause a worsening of their condition. So let me explain. So we see transient dysphagia in times of medical instability, so onset of some type of infection or illness, changes in medication related to those onset periods, and changes or changes in medication related to managing other chronic conditions. Transient dysphagia can also occur in times of psychiatric instability. So patients who are experiencing a manic phase can present with dangerous behaviors such as foreign body ingestion. So that's the swallowing of non-food objects. Or they might present with severe impulsivity. And so when they are manic and they're very, very impulsive, they have a pretty significant decrease in their ability for redirection. So that can increase their risks based on that psychiatric condition in that manic phase. Now, these types of transient episodes tend to cause characteristic declines in swallowing function that usually require some sort of short-term intervention in order for their swallowing function, which has declined, to return to baseline. So when we have that medical intervention, say we have medication adjustments, they recover from their urinary tract infection, then we see a return to baseline. But while they're in that declined area, we may need to put in supports and interventions to support them during that period. So the second category encompasses those acute onset disorders that any of us could experience in our lives. Things like stroke, Parkinson's disease, dementia, cancers, anything like that. What's important to really note is that in acute dysphagia, the assessment and treatment of dysphagia after things like trauma or disease in this population is often complicated by those co-occurring conditions. In the third category are conditions that are chronic in nature, and they're really seen as a worsening of dysphagia, and they're not readily reversed. And we see this often in those with a long history of psychotropic medication use. And this medication causes extrapyramidal side effects, things like tardive dyskinesia. And so we may see a long-term use causes a worsening of their dysphagia that is not really something that we can reverse. In chronic dysphagia, we may also see a worsening of things like esophageal motility, rather. And this may be because of the medication side effects. It could be because of physical deformities, such as worsening scoliosis. And that, in turn, can cause oropharyngeal swallowing declines. We also see that ordinary aging can result in declining feeding and swallowing abilities for those with ID. And this is likely because, unlike you or I, many of those with ID are already at their maximum functional ability by early adolescence. And as a result, they often have insufficient functional reserve to really compensate for things like, as you age, you have altered dentition, increased illness, and then also increased use or need for medication. Dr. Joan Shepherd made a lot of significant contributions to developing the evidence base and understanding the impacts of dysphagia in those with intellectual disability. So this here is a retrospective study that she did, and her and her colleagues did. And what they did was they observed 75 institutionalized adults with ID over a 10-year period. And they found a significant relationship between aging and dysphagia in this group. Specifically, they found that feeding and swallowing capabilities declined with age in people with intellectual disability. They also found that those with more severe functional deficits began to deteriorate at younger ages than those with milder ones. And ultimately, I believe that these data indicate that people with ID, those with ID, are at risk for negative consequences of dysphagia at any time during their lives. And so this means that timely interventions by speech pathologists is crucial for the early identification of functional changes, as well as for updating the management strategies that are being used. And in a setting where it's interdisciplinary team, other disciplines as well, we need them to be able to identify these changes so we can work together to update any strategies that we might need. So we do have some really amazing researchers who are doing who have made very important contributions to understanding the many needs of this population. As a whole, when it comes to dysphagia research, those with ID are often what I call the forgotten population. And because the evidence base for dysphagia management is really quite thin, much of our current assessment and treatment practices relies heavily upon expert opinion. The barriers to developing the evidence base in dysphagia management are complex, but despite these barriers, there is some really great work being done in this area. We just desperately need a lot more. So if any of you out there are looking for a topic for your thesis or your dissertation, this area is wide open and you are sure to find a question in which you can make that all-important, significant, original contribution to knowledge. So please go forth and ask questions and get answers. We need it for sure. If you want to know where we are right now and where you can contribute to the research, I invite you to take a look at this systematic review it was published just a few years ago. And from the 35 studies that were included in this review, Robertson and her group found that dysphagia is common in people with intellectual disability. It's associated with serious health risks, and it's likely underrecognized. They reported that while management practices such as diet modifications and alternative nutrition do exist, and we are using them, there are not nearly enough interventional studies and no randomized controlled trials to really evaluate their true effectiveness. So that's where we are right now. So in terms of assessment strategies and how do we assess somebody that has intellectual disability and may have swallowing dysfunction, signs and symptoms of dysphagia. So the assessment strategies for people with ID are the same as other adult onset populations. However, the timing and the need for reevaluation typically differs in this population. What we see is that screenings will occur as the individual's age, so from childhood through adult, and as they move from one setting to another. So a school setting to maybe from their homes to a group home setting or an intermediate care facility setting. Whatever settings they're transitioning from, they will likely get screenings of their swallowing function and lots of other functions as well. Now, clinical swallowing assessments are typically completed as the individuals move between settings, and sometimes they're completed as individuals move between clinicians. Referrals for instrumental evaluation typically occur when there's some kind of medical complication that appears to be associated with dysphagia, or when there's a need to transition between non-oral and oral feeding. While residing in any one center, periodic reassessment, both clinically and through instrumentation, will occur at regularly scheduled times, but you also will see those as needed. So if there's a change in function or a change in status, we may need to do both clinical and instrumental reevaluation. So as with much of the work in this population, there are many barriers to completing a thorough assessment of swallowing skills and abilities and of swallowing anatomy and physiology. First, the lack of standardized measures is definitely not unique in managing dysphagia in those with ID. In the past several years, the field of speech pathology has really focused on standardized ways to complete clinical and instrumental dysphagia assessments. However, many of these assessments cannot really be used in this population or used to their fullest abilities and extent because of the cognitive piece that is often impaired in those with ID. That being said, 3 really good standardized assessments that actually have been validated for this population include the choking risk assessment, the pneumonia risk assessment, and the dysphagia disorder survey. They were all developed by Dr. Shepard and her group. Another barrier to assessment in this group is an issue that I have faced many times, an incomplete medical history. So very often there are significant gaps in the medical record because as these patients transition from one setting to the next, the medical record often becomes fragmented. And then the specifics on the past medical conditions and the past medical treatments are fragmented as well. Sometimes they're there, sometimes they're partially there. And so, as you can imagine, for somebody that has a lot of co-occurring conditions, comorbidities, treatments, this becomes very challenging when you're trying to develop a plan of care for your newly admitted patient. Another barrier that I've faced is this issue of completing instrumental assessments, such as an MBS. I have a very good SLP friend who once said that getting an MBS is like getting abducted by aliens. And she says, you go into this weird cold room where everyone is wearing strange clothes and you're the only one eating, and you're eating this strange looking food, and you see this picture on the screen that looks like an alien, and this machine beside you is beeping and alarming every few minutes, and it's just a very, very foreign place, right? And for those who are not prepared for this, it can be an overwhelming experience that can escalate into challenging behaviors that ultimately make the completing the assessment virtually impossible. Another barrier that patients with ID often have is that they have a difficulty, they can have difficulty communicating their swallowing experiences to you. So you have to rely heavily on what their caregivers or their other allied health professionals perceive as their swallowing problems. And this, of course, leads into the issue of provider bias or confirmation bias, if you will. And this is where the caregiver, the team, or even the clinician tends to favor any information that confirms their previously existing beliefs about the individual's swallowing skills and abilities. So it's kind of like this. That doesn't look normal. So it's not normal. And if it's not normal, then it's abnormal. And abnormal is dysfunctional. But that type of thinking doesn't allow for atypical but functional. So just let me use myself as an example, just to kind of paint this picture for you. I am a wheelchair user. I've used a wheelchair for my mobility for most of my life. And much of the way that I go about my day is not normal. It's what I would call atypical. But because I've adapted, it certainly is very functional for me. But I still have therapist friends. I love them to death, but they cringe at the fact that my wheelchair has no brakes, I don't use a seat belt, I don't have a seat cushion, and the list goes on and on. And I can say, we can take that scenario and we can apply it to someone who maybe doesn't masticate with a perfect rotary pattern, or has anterior loss of the bolus during meals, but has never experienced a choking event and has a good respiratory health, right? Their past history for respiratory status is good. So there is much to be said about adaptation, and we really need to keep that in mind when we're assessing patients with intellectual disability, because it is likely that they have been, this is likely how they've been swallowing and how they've been eating for many, many years. Yes, it may be atypical, but unless there's some acute issue or acute change, this is likely very functional for them, and not necessarily that you have to jump in and make a lot of changes. So just keep that in mind when working with this population. So let's jump into the clinical swallow assessment. In this population, our clinical swallow assessment can really provide an incredible amount of information about the overall mealtime function as we observe the mealtime process. And, you know, I'm going to be totally honest here. There are times, many times in my experience, when watching someone with intellectual disability eat during his or her meal times is really the only way that I can complete the clinical swallow exam. And that's because of the cognitive deficit. So all of those wonderful things that we would normally do, we just can't do because they can't follow directions or, you know, do one steps, or they're, you know, aversive to you getting into their mouth and doing all these cranial nerve exams. And so you have to kind of watch the thing in action and make observations and then apply your clinical knowledge about anatomy and physiology and how the swallow works to come up with a plan of care. But I always caution, remember that our clinical assessments cannot tell us anything about swallowing physiology. And it can't tell us anything about the reasons for the signs and symptoms of pharyngeal dysfunction. So they might be there, but you have no idea why they are based on a clinical swallowing exam. But that aside, the nitty-gritty of the clinical assessment in this population will include an examination of those functional foundations of swallowing. And, you know, they're not swallowing per se, but they are the capabilities upon which swallowing depends. So the motivations for eating or not eating, eating pragmatics, the skills and sub-skills for eating and swallowing, these are all underpinned by those underlying competencies for swallowing that are needed for a safe and efficient mealtime process. So what can be very different from the traditional swallowing evaluation in this population is that there will likely be times when you are completing your evaluation. So as a speech pathologist, you're completing your evaluation, but you're doing it in conjunction with other disciplines such as occupational and physical therapists, nursing staff, and sometimes behavioral health clinicians. Now, this is especially true for those of us who are working in like a day hab program or intermediate care setting like the one that I'm in currently. So this slide describes those foundations that support swallowing function. So the physiologic foundations that you really should be thinking about in determining your patient's capacity for safe swallowing include those postural supports and body control issues that you want to make comment on and be looking at. Of course, oral motor movements for bolus preparation, voice for adequacy of vocal fold movement and airway protection. This may just be vocalizing, you know, not necessarily verbalizing, and it just depends on the person's verbal skills. Breath support for swallowing. Of course, any signs and symptoms of pharyngeal deficit, as well as any signs and symptoms of gastrointestinal function. We know that gastrointestinal issues are very high in this population. Between about 10 and 15% will have GI issues, and GI issues, it's all the same tube and they're all connected. So we need to always be thinking about what GI issues or gastrointestinal issues could be impacting my pharyngeal swallowing physiology. So psychosocial foundations refers to the behavioral competencies upon which eating depends. And so you can see these here. These are attention to the eating task and the ability to persist at that task. The use of eating pragmatics, which is the use of acceptable behaviors when eating. Compliance to the guiding adult in using any safe swallowing strategies that are required. Social intent during mealtime activities, and this is the ability to eat in a group and interact appropriately in that group. And then independence levels, which is the person's ability to participate in eating to the greatest level possible, given whatever their baseline capabilities are. So in this population, we often are trying to identify those contributing causes for a reluctance to eat. In doing so, we want to try to identify if there are any physiologic causes such as discomfort. I have a lot of examples in my practice where nonverbal individuals stopped eating due to pain, whether there was some type of infection such as esophagitis, or whether it was a result from injury to the oral mucosa or even dentition. So we need to pay attention to that. We should also be looking at whether or not there are food preferences that need to be addressed. Also, are the interactions with the eating partners acceptable? For example, are the direct care staff interacting with the individuals that they're supporting during their meals? Are they talking with them, or are they just barking orders? Is it a situation where actually their peers are having some sorts of challenging behaviors that are impacting their willingness to eat during meals? And of course, we need to assess any environmental factors that might be negatively impacting their motivation for eating. It really could be something as simple as the music or the TV is too loud. Honestly, I once traced about a 10-pound weight loss due to the addition of a karaoke machine that was being played in the dining area, and it was a pretty loud volume that was being played during the lunchtime meal. Once we addressed that, we monitored the person and we saw weight return back to baseline. Eating pragmatics is also very important to assess in this population. Poor pragmatic skills can significantly impact outcomes for safe and nutritious oral intake. I've seen instances where eating pragmatics of the social group have really influenced the person's willingness to continue to eat. I once had a patient he was MPO for several years, and as part of his return to oral plan, his return to oral intake, I was working on eating pragmatics with him, and specifically we were working on him not throwing plates or whatever he could get his hands on across the room whenever we brought him to the table. Now, for many months, he was unable to dine with his peers because of his deficits in these eating pragmatics, but thankfully, I worked with him and we did well, and he did well, and he now dines with his peer group. With respect to eating pragmatics, there are several factors that you need to consider. The ability to self-regulate during eating. So this has to do with your ability to regulate your excitement. So a patient is going to try and swallow, is a patient going to try and swallow an entire box of her favorite snack and then end up needing the Heimlich maneuver because she's unable to regulate her excitement over getting her favorite snack? We also want to look at the ability to maintain attention to task and not be too distracted to continue to eat. I once had a case where every time somebody walked past this particular patient while he was dining, he would reach out and grab that staff member, and then he would begin to laugh hysterically and start yelling out, and redirecting him back to the eating task was very, very difficult. So we had to do a lot of environmental modifications to his plan in order for him to successfully get through a meal safely and nutritiously. Also, the ability to comply with guiding adults during meals. So will staff cues for safe swallowing strategies be effective or not? And then the ability to tolerate any changes in the eating routine. So what happens when a patient moves from one unit to another unit and then they no longer recognize any familiar staff or peers? Will we start to see meal refusals and weight loss? Will we see increased incidences of dehydration and UTIs and hospitalizations for sepsis? Could this ultimately lead to a failure to thrive, and then ultimately necessitate the use of alternative nutrition and hydration to return back to baseline health and weight and nutritional status? All of these things are examples from my caseload at one time or another, and they all needed to be addressed in terms of eating pragmatics. Swallowing skills refers to the functional outcomes of eating, right? So for adults with ID, these skills may not have developed in childhood, or they may have been established in childhood, but they regressed or they were lost in adulthood. So during our assessments, we should be looking at each of these skills based on the demands placed of whatever prescribed diet they have. So for both eating and drinking, we're going to be focusing on things like their ability to eat with spoons and forks and drink with cups and even straws maybe. Their ability to process foods based on the texture. So non-chewable foods that you just put in your mouth and swallow versus foods that require biting and chewing. Their self-feeding skills. Their rate of intake stability. So not so slow that they fatigue and they burn up all their calories in the process, and not so fast that they risk choking or aspiration. For those who do eat orally, we should be observing their abilities to effectively transport the bolus from anterior to posterior oral cavity. So we're going to look at, most likely we'll be looking at the residue pattern that we see post-swallow. Is everything kind of left in there? Is it spread out all over the mouth, or is it clear? And because saliva management deficits have a higher prevalence in this population, we do also need to be sure and comment on their saliva management skills. Remember that the capabilities involved in saliva management require those same neuromuscular and neuromotor coordination abilities that we see in eating. So saliva management skills can really help to clue you in on kind of the robustness of the overall swallowing mechanism. So when you're examining saliva swallowing, you're going to want to make note of, their control at rest, during stimulating activities such as eating, and during parallel activities. And then, of course, we are interviewing the direct care staff and asking them, is what we're observing typical? Is this their normal level of function or not? Because they can change, they can vary. Because many factors can impact swallowing function for those with ID really at any time during their lives, scheduled reassessment is really required for managing chronic swallowing dysfunction in this group. In addition to regularly scheduled assessments, we also will do consultations or instrumental reassessments. They may need to be done because of acute illness, behavioral changes, meal refusals, maybe we're experiencing weight loss, or we're having caregiver reports of decline in function. So the management of dysphagia in those with ID really focus around these three areas that I have listed here. So first, it's important, of course, to maintain the health and safety of these individuals. And this often requires adequate supervision and assistance, and perhaps some diet restrictions and nutritional supports. But it's vitally important that we are trying to ensure that any restrictions are necessary so that we're not unduly interfering with their quality of life. And then, of course, maintaining quality of life is that second area. And we maintain quality of life by honoring preferences wherever and whenever we can, while also considering health and safety. One of the ways to achieve this is by providing the patient, the individual, with familiar environments, familiar care staff, and familiar relationships with their peers. We can also achieve this by ensuring fairly consistent routines, because we know that individuals with ID respond well to routines. And last, but certainly not least, is maintaining feeding and swallowing competencies. So if there's a chronic problem, or there's a problem that we see, oh, sorry, someone knocked on my door. There's a problem that we see deteriorating over time, we really have to be proactive in supporting the skills and abilities that are developed. So whatever's there, we want to make sure that we're doing our best to maintain those skills for as long as possible. So how do we do this? We do this by implementing and maintaining strategies for safe feeding and swallowing. And we might enlist the use of indirect training programs or direct interventions such as therapy. And then, of course, we're going to schedule reevaluation of function based on availability and be available, rather, for consultations as needed. So if there's anything that comes up before that reevaluation, we will be available to provide services. So the dysphagia management decisions that need to be made for those with ID are highly dependent on available resources. In this population, really quality of life outcomes depends on the resources that are available and the level of training that is given to the staff that make up those resources. So what we tend to find is that fewer restrictions are needed when there is sufficient monitoring of their health and their health status and their level of skill, and when there's adequate supervision and assistance that's available. So let's look at what can be regulated in daily care with respect to dysphagia management. We can regulate, and sometimes we have to regulate, the routines prior to feeding and swallowing activities. And we need to do this to ensure that the individual is, awake and alert and in an appropriate emotional state and able to successfully transition from whatever activity they were doing to any one of the swallowing activities that will occur throughout their day. We might need to regulate environmental structures such as the auditory and visual environments or the emotional environment in order to support optimal skills and behaviors. The amount of supervision and assistance from staff may certainly need to be regulated. Providing appropriate seating and positioning supports is very important. This is a really important component of dysphagia management in this population, because very often those functional foundations of postures and body control are, there's deficits in those areas, and we need to provide those positioning and seating supports to support optimal swallowing. Specialized equipment, of course. We may need specialized equipment to support safe and efficient swallowing activities. And then certainly the characteristics of the bolus may need to be regulated in terms of food textures and liquid viscosities. Safe swallowing strategies and communication modalities that we're using for regulating behavior. And we might also need to regulate the post-activity routines. So things like positioning for reflux management, or any type of behavioral strategies that we need to have in place in order to successfully transition from this activity, the dining activity, to the next activity. And of course, this dysphagia management plan is applied to any of the swallowing activities that are encountered in daily care. So this is an example of an individualized management plan that we use at my institution. This is called the Physical Nutritional Management Plan, or the PNMP. And this plan covers all of the identified physical and nutritional supports that someone at one of our facilities may need throughout their daily activities. With respect to dysphagia management, the PNMP provides information and staff instruction for diet modifications, safe swallowing strategies, the use of adaptive dining equipment, oral care needs, and positioning needs for oral intake or during enteral feedings. This is an extension of the PNMP that we call the dining card, and it's really a mini version of the dining section of the PNMP. It's a 5x7 card. It's laminated, has two sides to it. One side has pictures there, as you can see, with diet texture, dining equipment, and then how the person needs to be positioned during meals. And then the other side gives all the staff instruction for supporting safe swallowing during the meals. And all of our staff are competency-based trained on these physical nutritional management plans. So the physical nutritional management plan can be thought of as the therapeutic plan of care for that person, okay? So because of the multifaceted nature of dysphagia management in this population, there really needs to be an interdisciplinary approach to developing this plan. So this will include physical and occupational therapists who are going to oversee feeding, positioning and feeding independence needs, dietitians who will address the nutritional and hydration needs, the medical team who will work on medical issues and nursing care, and the dysphagia specialists who will work on feeding and swallowing issues. And all of these services are integrated with other plans. So the dysphagia management plan is integrated with the residential service plan, the nursing and medical care plan, the behavioral health plan, and so on and so forth. Everyone is working together for the most optimal outcomes for that person. But remember that you are only as strong as your weakest link. So if there's a breakdown or a failure in any one of these plans, it's going to impact the other and ultimately will impact that person that's being served. So let's take a look at a case study to illustrate this, the dysphagia management process that I've been discussing tonight. We have a patient here. We're going to call him Mr. X. Check my time. I'm doing okay. He is a 44-year-old, nonverbal, non-ambulatory male with multiple congenital abnormalities. His developmental milestones were delayed, but he was able to learn to feed himself. He was admitted to an ICF at his parents' request because they were no longer able to provide his daily care. So let's look at his diagnoses. It's a long list there, as you can see, but these are not all of Mr. X's medical diagnoses. They are the ones that I felt were pertinent to dysphagia management. Some of these diagnoses might not be ones that would jump out at you with respect to dysphagia. So for instance, you might be wondering, Melissa, why did you put bowel incontinence on there? Well, bowel incontinence can increase the risk of infection, leading to illness, which could cause that transient dysphagia that we talked about. Why blindness and hearing loss? The sensory deficits of blindness and hearing loss, especially when we have them both, can really impact the effectiveness of compensatory swallowing strategies that we might be thinking we could implement here. What else do we got? How about insomnia? Of course, decreased level of alertness can decrease safety during swallowing tasks. So if we've got a person who's up all night and then in the morning he is very sleepy and not so alert, then breakfast time might look a little bit different for him than it would if he got a good night's sleep. Diabetes insipidus. This is one that's interesting. The symptoms of diabetes insipidus can include things like extreme thirst, as well as increased urine output, so large urine output. Now, for Mr. X, he does display these symptoms. So he has an extreme drive to drink. He will drink anything he can get his hands on. And then this increased output that he has increases his risk for UTI because he's incontinent. So this increases his risk for infection and illness, which could lead to decompensated swallowing function. These are the kinds of things that go around my brain and what I think about when I'm doing a chart review on someone, and when I'm evaluating that person's risk levels in terms of dysphagia. Okay, the medication list. This is the next thing that I go to. First, I go to my diagnoses, then we go to the medication list. Again, I want to tell you that these are not all of the medications that Mr. X is prescribed, but they are the ones that are pertinent to dysphagia management. And just, take a gander at this list and notice how many medications have GI effects here. So dry mouth, nausea, vomiting, diarrhea, constipation. We have lots of medications on board that have the potential for those side effects. We also have CNS side effects, so central nervous system side effects that can impact swallowing function and swallowing safety and efficiency. So drowsiness, insomnia, tremor, twitching, loss of coordination. And we see medication side effects that can impact behavioral function, so increased anxiety and agitation. We also see some side effects that could impact nutritional stability, so things like anorexia, nausea, and even changes in taste. So those are all things you need to consider and want to have think about in assessing your patient. So Mr. X has been assessed via instrumentation on several occasions, as you can see here, and findings did vary over time, but the findings remained relatively consistent in observations of oral phase deficits and esophageal dysfunction. Over the years, he's been prescribed modified diets and thickened liquids of various consistencies. And based on MDS observations, he also had instrumentation of his esophageal function. And you can see there that the findings reported structural as well as functional deficits. So I'm going to show you an MBS next, and I have slowed it way down. So don't think that this is, when you see this, it's slowed way down so people can see what's going on. And one of the unique features of this case is Mr. X's diagnosis of rumination syndrome. Now, this is a relatively rare disorder in which a person volitionally brings up whatever they swallowed and they re-chew it and then re-swallow it repeatedly. And this MBS demonstrates this process very nicely. The first few swallows you'll see, they're fairly normal, and then we see rumination, and then we see some more normal swallows, and we see it again. And what's important to note here is that this rumination is not dependent on the type of diet modification, okay? In this example, we see that he ruminates on both thin and thickened liquids, but not on pureed solids. Okay, so number one is a thin liquid, and then we go to number two, which is a thickened liquid, and then 4 is pureed solids, and we see that process there. Another aspect here is that diet modifications or thickened liquids do not mitigate aspiration risk in this situation, okay? Because his aspiration risk is derived from that retroflow of gastric contents. And because there's no biomechanical impairment, dysphagia management in this situation should not include diet modifications as a means of mitigating pneumonia risk, okay? However, we do certainly want to consider the impacts of this behavioral disorder on his pneumonia risk, not because of the diet texture or the liquid consistency, but because of the regurgitated materials from his stomach. We also need to consider the long-term impacts of pharyngeal dysfunction from those esophageal changes that are resulting from his rumination behaviors, specifically that dilatated esophagus that the upper GI identified in 2016. So this is Mr. X's annual clinical swallowing assessment. And during this assessment, we examined all those aspects of swallowing that impact safety and independence and quality of life for Mr. X. This assessment was completed over several days, and it was done in his home environment and in conjunction with multiple disciplines, so OT, PT, and speech. In terms of his physiologic status, we noted that Mr. X had adaptive dining chair, but he wasn't using it because he was refusing to get in it. He wanted to stay in his wheelchair and would refuse to get into the adaptive dining chair for his meals. So we did see him in his wheelchair, and we determined that his wheelchair definitely provided him enough support for good upright positioning during dining. So that wasn't an issue. In terms of his psychosocial status, Mr. X was observed to be extremely grabby. Even as you were assisting him to the table, he was reaching out for anything that was in front of him. Mr. X was also quite distractible during meals. Throughout the meal, he would stop and he would reach out and touch the staff members that were beside him and that were assisting him. But we did see that he did respond well to staff redirection and consistent verbal cues to get back to the eating task, so that was good. In terms of his oromotor skills, he had deficits in oral containment, and it didn't matter if it was solid or liquids. He appeared to have difficulty with bolus transport. There was a fair amount of stuff left in his oral cavity after he would swallow. He also had limited visual awareness, and he needed some tactile cueing from the spoon or the cup before he would prepare to open his mouth and be ready to take a bite or a drink. But when he did eat and drink, he was not observed to present with any signs or symptoms of pharyngeal difficulty. And lastly, Mr. X was observed to have the physical ability to feed himself, so he could hold a spoon and he could hold a cup and he could move his arms. But he was, it was his impulsivity and his limited abilities for redirection, which really necessitated the need for full feeding assistance. Our assessment findings, when we pulled them all together, we found that, over the last year, he had done well with his physical nutritional management supports. And we really based this on the fact that he has remained free from adverse events related to his feeding and swallowing deficits for the past several years. And as such, all of the supports that he has, we said, should continue. And of course, he should continue to be reassessed annually for any changes, and we would be available for consultation in the meantime. One key aspect of this case is the need to have a really good understanding of the risk factors that need to be considered when you're developing your management plan for those with intellectual disability. It is never as simple as, did he aspirate or not? What did the MBS say? It's just never as simple as that, right? So in this case, Mr. X, his aspiration risks are clearly weighed more towards his behavioral disorders and his sensory and cognitive impairments than on any swallowing dysfunction or pharyngeal swallowing dysfunction. And because of this, he needs pretty significant supports in order to safely participate in his mealtime. But in terms of his quality of life, because he's provided with this level of support, he's able to have the opportunity for those social interactions that we all desire during meals when we eat, right? So he's able to dine with his peers, and he's able to interact with his staff multiple times a day. And he's able to go out to eat with his peers. And this is something that he really loves to do. So this might not seem like much, but when you see patients who, because of their level of impairment, are fully enterally supported and they don't have these kinds of opportunities, you quickly realize how important it really is. And you also become keenly aware that because of this patient's complexity, positive outcomes like this are really only possible with consistent and continual management and monitoring by everybody that is involved in his care. So to summarize, having systems in place for identifying, assessing, and treating dysphagia in adults with ID is essential because these patients tend to be very complex patients, and that requires system management. Having regularly scheduled follow-up will allow us to anticipate their needs with proactive and preventative care, with prompt attention by healthcare professionals and allied health professionals. But we must also be regularly coordinating with all the other stakeholders that are involved in this person's care. So the medical, the educational, the allied health stakeholders, and then of course the primary stakeholders, the patients themselves, their caregivers and their family members or legal guardians. So if we have these systems in place and we're able to implement them, we will be doing much to support optimum function, health, and ultimately quality of life for those with intellectual disability and dysphagia. So I just want to thank you so much for your kind attention during this webinar. I know it was a lot to talk about in 1 hour. It's so great to see that there are so many others out there who are as interested as I am in this topic. So thank you again for giving me the opportunity to talk. And of course, I look forward to answering any questions that anybody might have.
Awesome. Melissa, thank you so much for your presentation.
Sure.
That's wonderful information for our community. We have tons of questions. I don't know if we'll have time to get to all of them, but there's one that I want to start with that several people asked. They were wondering if you could repeat the standardized assessments that Dr. Shepard had outlined for the risk of dysphagia. So I think they're talking about the choking risk assessment, I think probably around slide 20.
Yes. Oh, okay. And I don't think I should have listed them. And I do believe I put them in my references.
Okay.
So that's going to be the choking risk assessment, the pneumonia risk assessment, and the dysphagia disorder survey.
Okay. And where can people find those? And are they available for free?
The choking risk assessment and the pneumonia risk assessment are in Dr. Shepard's, the appendix of Dr. Shepard's paper that that validated the one that validated those assessments, and then that's in my references. So you can go to that paper. I believe it was 2002. But the dysphagia disorder survey, you have to be certified. Let me see if I can find that reference here. The dysphagia, yes, the last one, 2001, the last reference there on my slides, and it should be in the PDF. That one, if you go to that, you will find those two assessments, the choking risk assessment and the pneumonia risk assessment. The dysphagia disorder survey, if memory serves me, the last time I checked on it, you had to be certified to be able to use it. So you had to kind of take a course on doing that. The last time I checked, that's what I was told. But that was before Dr. Shepard had passed away, so I don't know if that's still the case or not. That's the best answer I can give.
Thank you. The next question I have, somebody's asking if you have a good reference for medications that can cause or contribute to dysphagia.
Oh gosh, yes. I have this great little book, the Dysphagia, it's a red book. I'm going to think about it off the top of my head. I think it's medications. Oh, I can't think of it off the top of my head. I use it all the time, and the other place that you can go is, let's see, I believe Dysphagia Cafe printed a list of they did a write-up on dysphagia and medication side effects. But I can't think of who wrote that one. I'm sorry.
That's okay. If you think of it, we can always send it out to the person.
I have it. I just don't, I can't think of it off the top of my head, so I can get that out to
No
you.
worries.
And
Melissa,
anybody can email me anytime, and I can answer questions there too.
Excellent, thank you.
Sure.
is it called Drugs and Dysphagia?
That's it. It's a little red book. Love it.
Excellent. Thanks, Ed.
I don't know who the author is though.
Let's see, I have another question here for you, Melissa. Somebody's asking, do you feel that people with ID should automatically carry a diagnosis of dysphagia?
Definitely, I would say, I'm going to say no, because there are a lot of people that have no swallowing dysfunction. So in terms of, you know, some sort of dysfunction in their oral pharyngeal swallowing, but maybe they have behavioral issues or other issues that require additional supports to make swallowing safe, but that's not dysphagia per se. And I would never want to make a blanket statement that, you know, everybody that if you have ID, you have dysphagia. I don't think that the literature is there to support that. And so we would definitely need to know more about prevalence and incidence of dysphagia in this population, and that's something we just don't have any information on, or not a lot of at this point. Great question.
Yeah, we have a couple of questions here. I'm going to kind of combine them. I hope I cover the questions okay here. There's a few people that are asking about the literature and your thoughts and what you've seen in your clinical practice about patients with ID and feeding tubes.
Okay, so that systematic review that I had talked about, one of the things that they mentioned in that review was the use of feeding tubes. And in their review, they said that they found positive outcomes for the use of feeding tubes in this population. But I think you have to be really careful with that, because a number of papers that they were actually able to use, I think it was like 6 or something like that. It was a very low number. And the positive outcomes that they were reporting were based on caregiver reports. So either the caregiver said they felt that they were doing better, or the medical professional said they felt that they were doing, that the person was doing better. So whether or not that is actually true for that person, we don't know, because we don't have their account of whether or not they feel like their outcomes have been improved by the use of a PEG tube or not. So it's something that we use in this population. There are times where swallowing impairment is so profound that it's the way that we have to implement that in terms of providing nutritional support. But other times, especially in patients that are aging and getting older, we don't have the literature or the information to tell us, is this appropriate in that population? You know, just like we have the literature now that says it's not appropriate to be using PEG tubes in those with advanced dementia. Is it appropriate to be using PEG tubes in those aged individuals that are, you know, having swallowing function and swallowing declines, and we place a PEG tube? Are their outcomes any better or not? Are we improving their quality of life or not? The literature and the research just isn't there yet.
Thank you for that answer. I'm going to ask one more question, and then I will send you the list of questions that we have, just in case there's some that we don't get to tonight.
Yeah, sure.
For you is, what are your thoughts about going off a bedside evaluation to treat dysphagia in patients with ID that aren't able to complete a video fluoroscopic study or a FEES exam?
Yeah, great question. Happens to me. It's happened to me. I will tell you, I've not, at my institution, we don't do FEES exams. It's just not something that we've talked about or considered for a variety of reasons. A lot of it is just the lack of the person's ability to understand the process of what's going on. I'm not saying that fees cannot be used in this population. It's just not anything that I've experienced. Or even I think in the cases that I've worked with would recommend, just because I know that the cooperation piece would make it challenging. But there are instances where the modified barium swallow study and being able to have that objective measure of the pharyngeal swallowing function could not be done. You know, the patient ran out of the fluoro suite. That's happened, and we can't get them back in. Or the patient refused to come into the fluoro suite. That's happened. And so in those instances, documentation is the key, okay? You have to document your attempts at doing instrumental assessments, the reasons why they weren't successful, and then of course, as a team, you want to try to address those reasons and see if you can overcome those barriers in order for that person to participate in a modified barium swallow study, because it's of vital importance. I would never say that, you know, we couldn't do it once, so I'm never going to try it again. I would say that we couldn't do it, so based on my clinical assessment in this person's medical history, these are going to be my recommendations. But included in those recommendations will be can we overcome the barriers of completing an instrumental assessment. And I've had people on my caseload that I've begun treatment with. They were maybe NPO for a long time, and I knew that one of the barriers was going to be oral acceptance of anything. So I had to work on oral acceptance of you know, teaspoon sips of water before I could even get them to a modified barium swallow study to participate in the modified barium swallow study. So there are times where you have to attack it that way. If you know that participation is going to be a problem, maybe you be proactive with that and try to address it up front and make it so that you can make it possible for participation in the MBS. Or if you tried to do the MBS and participation wasn't possible, what things can you implement in the strategy and in the treatment plan so that maybe down the road participation could be possible. But that situation happens where you don't have anything other than the clinical swallow assessment to make your recommendations. You just have to document it.
Melissa, thank you so much for answering these questions.
Sure.
At this time, I invite Ed to come back on and give a few closing remarks, but thank you so much for taking the time this evening to present. We really appreciate it.
Yeah, it was a great, thank you so much.
Yeah, Melissa,
Yes, sir.
you have such a deep knowledge and feeling toward this population. Was there some impetus or event that prompted you to focus on this population that you want to share?
Yes, no problem. So vulnerable populations have always kind of been my thing. Before I started working with those with intellectual disability, I worked with trach and vent populations. I worked with individual or patients with dementia and things like that. And when I had the opportunity to come here, it was kind of like all of the parts of being a speech pathologist in terms of supporting people's ability to communicate their wants and needs and desires, in addition to the basic needs of eating and swallowing, really all came together in this population because both of those pieces are often impaired, and it takes that multidisciplinary and kind of holistic approach in order to support them. And I just found that to be such a rewarding population to work with, because it takes all of my skills and abilities to get the job done, which I find very intriguing and rewarding.
Well, it shows. So congratulations. on finding something that you're passionate about.
Thank you so much.
Yep. Thank you for being our keynote speaker tonight. We had over 500 people attend the webinar this evening, and a ton of questions. So we'll look through the questions, and if we didn't get to one, we'll see if we can circle back to you and answer and out to the people who asked. So
Absolutely, that sounds great.
Yeah, so thank you for joining us today. I would like to thank all of our participants for joining. Within about an hour, you should get an email from us with a certificate of attendance, and within a day, you'll get another email from us with a 2-minute survey about tonight's presentation. And with that, I wish you all a good day or a good evening, and I hope that you'll join us for our next webinar. And once again, Melissa, outstanding job. Elizabeth, outstanding. Thanks you all.
Thank you. Have a good evening.